Dr. Kightlinger, thank you for joining us tonight. This is what we're calling our first Viking Voices webinar. We're planning to bring meaningful dialogue and discussion in this uncertain time. We also recognize our community is feeling the pain of COVID-19. At Augustana, our graduating seniors left for spring break, expecting to be able to be refreshed and to return to finish the sprint to the finish line, only to discover the entire world had changed while they were gone on spring break, that they wouldn't be able to hug their friends and roommates goodbye at commencement, to celebrate as a class, but instead finish their coursework from home. We also have around 150 students who remain on campus, many of whom are international students who simply have been unable to return home and now face a pandemic away from the comfort of their family and loved ones. And everyone sees the news. Sioux Falls is also reeling. We now have the largest hotspot outbreak in the nation. Nearly 1,000 have become sick, and many more are expected to do so. People are anxious. At the Helpline Center, requests for food in the month of March alone equaled half of all requests from the entire year of 2019. And we know the road ahead might be bumpy. And that's why we felt having Dr. Lon Kightlinger with us was so important. He's been at the front lines of pandemics, including HIV-AIDS, Ebola, the plague, measles, and now COVID-19. He brings a wealth of public health history and a nonpartisan voice. Lon Kightlinger proudly hails from the prairies of north central South Dakota. His Augustana education was broken up by being drafted into the U.S. Army, but he eventually graduated from Augie in 1977. He later achieved a Master of Science in Public Health from Tulane University in New Orleans and a Ph.D. from the University of North Carolina in Chapel Hill, specializing in infectious parasitic diseases and epidemiology. He worked in Madagascar from 1978 to 1998 in medical and public health service. And following his work on the other side of the globe, he returned to South Dakota, where he held the position of state epidemiologist for the South Dakota Department of Health for nearly 20 years. Upon reaching the ripened age of 65, he retired and sent his career full circle by returning to Madagascar with the Peace Corps as a health volunteer. However, due to the COVID-19 pandemic, he was evacuated back to the USA in late March 2020, along with all Peace Corps volunteers worldwide. After a self-quarantine period, Lon went to work with the Department of Health to help control the coronavirus. Tonight's webinar will operate largely in a Q&A format. Dr. Kightlinger has been gracious to join us, but his quick evacuation from Madagascar meant much of his belongings and his housing isn't yet settled. A series of questions was created ahead of time, and depending on time, he may be able to answer some additional questions. Tonight's webinar will be streaming on Facebook Live on the Augie alumni page and will be available after the event. Thank you for joining us, Dr. Kightlinger. I'll let you read the questions and provide your insights.
Okay, thank you. Yeah, this should be fun. And I'm not sure what a great COVID expertise that I have here, because a month ago I was happily serving in Madagascar, far from the internet, far from all this world tumult. And we received an order from Peace Corps headquarters that all 7,000 Peace Corps volunteers all over the world were to be evacuated back to their home of record. And the evacuation was tumultuous and exhausting from Madagascar. There were 200 of us. We spent a couple days in Ethiopia and then on to the United States. I came back here to Pierce, South Dakota, where my son arrived a day or two ahead of me, found this house. This house is like a museum that we're living in. We're very comfortable, but I don't have my stuff. I'd like to get moved back in. So I've been through a very chaotic couple of weeks here, especially being evacuated with Peace Corps volunteers. Most of them are like Augustana recent graduates, very young, emotional, energetic, and exuberant. There were, however, a couple of us old fogies in the evacuation, and we were able to settle them down a little bit. And I did my 14-day self-quarantine back here in Pierre. And I volunteered to work for the South Dakota Department of Health. So I'm actually working at the health department. Again, I'm no longer a civilian, and I'm no longer doing the state epidemiologist position. I'm doing some mid-level epidemiology work, which suits me fine. I'm just helping out, but I want to make sure that you know that I'm not the spokesperson for the health department anymore. I do not speak for the health department, and I'm not going to critique it at all. But I will talk about, just to give context, some of the outbreaks and pandemics and epidemics that I've been involved in, because these things happen. Okay, so thank you for sending me the questions that you've been able to gather. The first one is just what is a pandemic and how do you define it? Well, you start with one case, one person would be a case. And then if you have a couple of them, usually a couple of kids in a school or a daycare or a family, you call that a cluster. Because if you go to the next level and call it an outbreak, that sounds very ominous, especially since they made a movie, a very scary movie with that name. So we don't want to use that word outbreak too often. But that would be, oh, you'd have maybe 20 people with a disease here in South Dakota, and they're all somehow connected. That would be an outbreak. And then if it gets bigger, really gains a lot of numbers and goes more than what you expect for a disease in a particular locality, I usually would take the 5-year normal, the 5-year median, and consider that our normal. And if we went anywhere from 25% to 50% above that, we would be an outbreak. And then if neighboring states of Minnesota or Iowa or Nebraska or North Dakota or someplace was also involved with it, we'd call it an epidemic. And we can do that. Maybe we need more funds, we need more resources, we need more media attention to get people's notice. We'll call it an epidemic. But a pandemic, that is at the top of everything. That is global. It's global and it's bad. So we have a new virus out there, a virus that has never circulated in human population that we know of. And I think almost every country in the world now is experiencing it, and it's making a lot of people sick and it's killing a lot of people. And that is a pandemic all over the world. So that was the first question. Then the second question is, what is COVID-19 and how is it unique from other coronaviruses? Every year we have your generic coronavirus illnesses in people, and they cause winter respiratory illnesses, very much indistinguishable from the common cold or the sniffles, or they're not even diagnosed all that much, but if you're out looking for them, you will find them. We've had coronaviruses that have caused problems. In 2003, there was the Sars outbreak, again from China. South Dakota, we didn't have any cases. We had some suspects that we worked up. And the United States had, I think, less than 10 cases in the United States. Toronto, Canada was hit hard. They had a hospital situation that got out of control. So Toronto was the center of that outbreak. Then there's the MERS coronavirus. That's the Middle East respiratory syndrome that comes from camels, evidently. And again, we've had a few suspects, a few people of interest here in South Dakota, but never a confirmed case. But that's another coronavirus. Then this current virus, it's small, it's about 100 nanometers. All it is, it's a ball of RNA wrapped in a lipid covering with some protein spikes sticking out of it. And it's in bats. Bats carry a lot of coronaviruses and other interesting things. And somehow in China, there was some transmission between the bat and maybe some other animals into the humans. And then usually that's a dead end in one person. It's not easily transmissible human to human. But for this particular coronavirus, which has since been named, well, given the disease name COVID-19, it became easily transmissible human to human, kicking off a few cases, first a cluster, then an outbreak when it became an epidemic in China, and now it is the pandemic. So we have a new virus, a novel virus that has emerged, and what makes it so bad is none of us have seen it before. So people don't have immunity to it. So we're all susceptible. We're all vulnerable. We could all contract the virus. Some of us would get sick, and they say that about 80% will get the virus, but it won't bother them too much. They may not even know it at all, and about 20% of us will become sick from us, and 1 to 2% or so of us will probably die from it. And it came into being. The next question is, I've kind of answered it already, but it's a zoonotic disease coming from animals into humans, and we're seeing this more and more often, especially from bats. SARS, as I mentioned, originated in the horseshoe bat in China. Nipah virus, Hendra virus, I believe, Marburg virus. There's a whole list of them. The most notorious is Ebola. Ebola virus comes from a bat too. And that was first described in 1976, right about the time I got out of Augustana, or I graduated. So I've been interested in this and curious about Ebola my whole life. So back in 2014, 2015, when we had the big Ebola outbreak in West Africa, I volunteered to go over there. So I went over there. I left South Dakota for about a month and a half and went to Guinea and helped work on the control team for Ebola. So I've seen what these viruses can do. And I've seen lots of outbreaks. When I worked in Madagascar, lots of diseases that we don't have here in the United States, and here in South Dakota, many diseases too. But this is different. The other diseases that I've worked, well, maybe not Ebola in Africa, but the diseases here that we've had in South Dakota, it's been the disease and you control the disease. Occasionally, we'd ask a school to maybe shut down for a day or two or over a long weekend. A restaurant, shut a restaurant down if some bad food was there, or put a moratorium on a nursing home or something like that. That's what I've been involved in up until this point. But now this is different because every school in the state is closed. Most businesses are closed. The university is closed. So what we're experiencing now is absolutely unique, and I'm kind of glad that I'm retired and don't have to really face the music for it. But I'll pitch in and do what I need to do. The next question is, how is this different from seasonal flu? Well, with seasonal flu, I hate to say it, but it's our old friend. It comes back every year. Every year, about October or November, we start seeing a few flu cases. They build up. And usually here in South Dakota, it's usually mid-February or so. It'll peak and then it'll go down. We have A viruses of flu, and we have B viruses of influenza, the H1 and the H3 strains. So they just become old friends or old enemies to us. And flu every year, it's always changing. It's always evolving. Hence, we need a new vaccine every year, because flu virus is very unstable. It's always changing. However, back in 2009, 11 years ago, the H1N1 so-called swine flu virus emerged, and we had another pandemic. And that was actually, we could actually consider that almost a dry run for this, because as much drama as that produced, as much disease and mortality as it produced, it was actually a mild virus. And we had a vaccine. It emerged in April, and by October we had a vaccine. So we were able to start vaccinating the population of at least our state here in South Dakota, and other states as well. And that virus that emerged back in 2009, it's still with us. It still circulates. Every year it's changing a little bit, but it's the same mother virus that emerged back that year. Then the next question is, well, how do you get it? How do you get this? And do we know if it's aerosolized? Well, it's a respiratory virus. So we get it, it comes out of our mouth and it comes out of our nose and it goes on to another person. Typically it's droplets, like as we talk, as we cough, as we sing, as we sneeze, little droplets of spitlet come out. Sometimes you see them, most of the time you don't. And that's the main culprit. It can go on surfaces too. I sneeze in my hand, here's my Kleenex, I don't have my Kleenex, I throw it down, I touch the doorknob or I touch the pencil, the next person that gets it, they touch their mouth or their nose or their eye, and they can get it. And then now we're learning more about this new coronavirus, this COVID, and the thought is now has been demonstrated to some extent that it can be aerosolized, which means you sneeze it out and it can hang in the air. It can just drift about in the air, like the measles virus does. And that makes it even more dangerous because you can sneeze over here and 15 minutes later, somebody can walk through there and the virus is still hanging in the air. And that makes it particularly dangerous, and also particularly dangerous because you may not even be sick. You may not have a fever, and you may be putting out these viruses. What about masking? There's a question about masking. Well, I had my Kleenex here. You know, we always say, cover your cough, cover your sneeze, go into that. And if you don't have your Kleenex with you, and then cough into your arm here. Well, if you're out and about, there's ways to do that. What's being touted now is the cloth. So I've got this, I've got this cloth mask here, and you know, I hate to say it, but these really aren't very effective. They're not. They're probably minimal protection here, but they're better than nothing, because we really don't know, you know, what is it made out of? Is it made out of cotton, or is it made out of polyester or nylon or linen, or what the heck is it? And how big are the pore sizes? Can we sneeze through it? Does it get saturated with our breath and cause more problems, or does it not fit tight enough and just give us this sense of confidence so we think that we can go out and go anywhere when it's really not protecting us all? So the science is still out on this. We don't know. It hasn't been studied well enough. You know, science does not have all the answers, but I think, you know, CDC is now recommending it, and a lot of cities are recommending it because it's better than nothing. But please don't put all your 100% faith in that. The next level up is the surgical mask. And that's actually manufactured. You hook it around your ears, and this is what you'll see in clinics and hospitals. They may put this on, and this is what's called a source protector. So if I'm wearing this and I'm back here coughing, the cough is going to get caught in here, and it's not going to be spewing at people. However, this is not going to protect me if you're coughing, because you're going to cough and I'm going to breathe it in because it's not a tight seal around my face. So the next level up is what's called the N95 respirator. And this has a little like metal thing here that you press around your nose, and you have to be fit tested for this because there's various sizes for this. And I have this from several years ago when I worked at the health department, and I carry it with me when I go on planes and things like that, just in case I get stuck in the middle seat by somebody who's coughing a lot, and then I'll pull this out and put this. So so I have this, and this is fit tested for you, and it fits around your mouth and your face, and this is what they're going to be using in the hospital to protect the healthcare worker from the infectious person. And then there's other levels that are even higher, the PAPRs, where you put a hood and a face mask on you. But oh gosh, I guess the ear things fall off that my son gave me when I'm putting these on. And these are made in Aberdeen, South Dakota. So, you know, we're doing our part here. So that's about, oh, and then you've seen people, or if you don't have anything, like here's my old dirty t-shirt, you can put that around your face and go out. You know, again, I don't know how good it is, probably minimally, but it's better than nothing. And I was at the store the other day and I saw somebody like this. Well, this is probably maybe 0.1% effective, but we're almost making it up as we go along here. I guess it just shows how well we are prepared. So another question is, what steps should we take when we're shopping? Well, first of all, get yourself organized. Go there with your list and do no frills shopping. Go through and you know where you shop before, get an idea of how the aisles go, get in and get out as quick as you can. You know, wash your hands before you go in and wash them when you get out. Wear your mask. They want you to wear a mask now, even if it's, you know, minimally effective. You could be protecting somebody else, and you could be helping the cause just by wearing it. And keep your distance. Keep your physical distance from you. Keep, you know, within 6 feet of people. And then once you get out, go wash your hands and get yourself home. And go once a week. Don't go every day. Just get your list, get yourself organized, go in, no frills, do it as fast and efficiently as you can, and don't dawdle. You know, before we'd go in and we'd look, and I'd go from the store, I'd go, back and I'd look at the kayaks, and I'd look at, all kinds of other stuff. And, now is not the time to do that. Just get in and get out with what you need, get your food and get it done. And be safe and be socially distanced about it. And coming back from Madagascar, going to the grocery store here, you run into people that I haven't seen in 2.5 years. So they want to talk, I want to talk, you want to give them a hug, you can't do that. You can't even talk that long. So make it quick. Then the next question is, how do you protect yourself from your family and your loved ones? And would you take more precautions about essential workers? Well, around your family and your loved ones, if you've got high risk people in your family, take special precautions. And high risk are anybody that's old, over 60 or over 65, or anybody with underlying conditions, especially respiratory illnesses. They're on cancer chemotherapy, any immunosuppression regimen they're on, diabetes, high blood pressure. All these are high risk. Just those people should be, really paying attention, and you shouldn't foist yourself on them. I came back after 2 years here, and I went up to see my mother. She lives about 90 miles north of here, up in Selby. And I stood way over there from her on the driveway and said, "Hi, Mother, I'm home." And she's 92, so she's fine. And if you're in quarantine with somebody for high risk, you can wear your mask at home. And then check your symptoms. Just check your symptoms. If you feel like you're getting sick, pull out your thermometer and check it. And I know thermometers are hard to find these days. You can't buy them here in any store in Pierre that I found. But we should all have that in our medical kits. So just pay attention to your own health, and just do all the self-quarantining and self-isolation things that you have to do, especially for people who are at high risk. And if you do feel sick, when should you seek medical attention? Well, fever and cough, that would be the two hallmarks of this disease. And like I said at the outset, 80% of the people probably aren't going to feel very sick at all, and they're probably really not going to need to seek medical attention, but they will be infectious. Not sick or mildly sick, but still infectious. But if you are sick, if you are running a fever, if you are coughing, if you are just feeling bad, call ahead. Call ahead to the doc that you usually go, and call ahead and tell them what you got, and they'll tell you, because maybe they have a separate door, or maybe they have somebody in the parking lot that'll hand you a mask or take your temperature out there. So now is not the time to just think, oh, I've got to stay home. I got to stay home because everybody in the hospital's on a ventilator and I can't possibly go. Just, take care of yourself, and your body better than anybody else, and call your doc and go in especially if you're feeling that fever. Now there's a question about if you really can't do your shopping, and it's about takeout food and delivery service. I know here in Pierre, South Dakota, people want to support the local restaurants and their favorite food places, because just as a community service to help them out. And by all means, do that. I also urge people to cook at home. We've got more time to be at home, so explore some of those recipes that you haven't done. Don't gain a lot of weight, but refine your cooking at home and order out. If people are delivering, that's fine. I'm seeing a chat here from somebody I knew in Madagascar, and I'll say, Michelle Tutupku, Shalamihanyahu. Shalama kanefa malahelwa sitria sitapachuni fatuku ani Madagascar. Okay, now back to English again. Okay, the next question is about, it seems like males of all ages, are more susceptible in females. Well, I don't know. us men, we are the weaker sex. Our life expectancy is lower. We die earlier than the women. And I don't know if it's that Y chromosome or what the heck it is, but we just aren't as robust. Our immune system isn't as good. We don't take as good a care of ourselves. We don't, a lot of men are smokers, and that pushes our lifestyle down. We take more risks. That pushes us down, but women are able to withstand this disease and other diseases just better than men do. I won't say we work harder, because we don't. I guess probably traditionally maybe more physical labor, but I don't think really that's true anymore. But for us older people, I don't know. And if you did a lot of physical labor as a young man, I don't know, maybe that wears you down. But it's just a fact. Men's life expectancy is lower than women. For babies, infant mortality, the infant mortality for baby boys is higher than for baby girls. And I don't really know all that is. And young and old too. You could just compare, why are young people able to survive this COVID disease more than older people are? Well, that has to do with our immunity. You get older, your immune function just is not as robust as it used to be, and you're not able to withstand these. Your lungs get stuff in it. Your white blood cells, your antibodies just aren't what they used to be. You don't respond as well to the vaccine. The response to even the common flu vaccine is much lower in the elderly group than it is in the young group. So it's just something we have to know about. But then again, that's why the elderly are at higher risk, and that's why they need to be protected. The next question is, gosh, and this is the hard one too. How much longer do you believe it will be before readily accessible testing is available? Gosh, that's a question that's being debated all across the country, all across the world now. We need accessible testing. We need accurate testing. We need reproducible testing. We need affordable testing. And I don't know, I feel it's going to be, it's not going to be this week. It's not going to be this month. It's going to be a long time. Think of the HIV test. How long, we've got a lot of scientific skill behind us to develop this test. But if you wanted an HIV test today, you would have to jump through some hoops. If you wanted a pregnancy test, it used to be you had to go to the doctor for that. Now you can do one in your home. There's home glucose tests and things like that, but that's testing for, like glucose test is testing for a chemical in your blood. An HIV test is something different, but then we validate that. It used to be through a Western blot, and there's rapid tests. And what's happening now is so many places are developing the test. Some have a lot of false negatives, others have a lot of false positives. Sometimes you test a person today on Wednesday and they're positive. You test them again tomorrow, they're negative. So it's not really all that producible. So we've got a long way to go on testing. We're not there yet, and it's going to take a while. I'm not hopeful on this. We had a little measles outbreak here in South Dakota a couple years ago when I was state epidemiologist, and just the standard, the IgM test, just proved to have so many like confounding factors, and I don't know, it's just hard. So I'm not holding my breath on that, but it will come, and hopefully it will be affordable. And I hear now they want to use it as like almost a key to get back into circulation. If you've got that test positive, but then if you test positive, if you have IgM, or you can show that you have IgM or IgG, does that mean you have immunity? We need to study this, and to do actual population-based studies, that takes a long time. That'll take years to do. So we're just learning about this virus. It only emerged in late December, and this is only mid-April. So we've got a long ways to go with this testing, as well as the vaccine. The same thing can be said about the vaccine. When I started my career, the promise was the malaria vaccine would be soon available. Well, it still isn't. It's still, only being, very sparsely deployed in about 4 countries in Africa, and it's not working very well. Same with HIV. Remember back in the early 1980s, the thought was, oh, we're gonna have an HIV vaccine here very soon. Here it is, 2020, 40 years later. Where's the HIV vaccine? Same thing with West Nile here in South Dakota. When West Nile emerged, we had an epidemic here in South Dakota. In August of 2003, we had over 1,000 cases of West Nile in South Dakota. We had 14 deaths in that short period of time. There was panic. And the promise was that soon there'd be a West Nile vaccine, and it should be easy because we already have a yellow fever vaccine, which is another flavivirus vaccine. You just manipulate that a little bit and off we go. Well, we still don't have that. So, but I don't know, this is a pandemic. This is much higher stakes. So hopefully they'll be putting like billions of dollars in it, and the best minds in the country and the world will be working on this. And we will have a good, safe, effective vaccine here within a year and a half. I don't know, I just heard Anthony Fauci say a year and a half, but he was very guarded in his statements, so I'm not going to try and contradict him or be more hopeful than he would. Let's see. Okay, the next testing is about modeling. Now, oh gosh, I'd say just, I don't know, don't look too seriously at these models. And I used to love models. I'm a parasitologist in infectious disease, and I used to follow that stuff a lot and used to work on it in Madagascar with schistosomiasis and hookworm and some of the other worms there. You screen all the kids in the community, and then you target, a segment of the population, say all kids 5 to 12 years of age, and you treat the positives and you educate them, or you do mass deworming of all the kids 1 year or 2 years, and you model that out, like how many years will it take, like to completely eliminate the parasite, the schistosoma parasite, or the worm from the population. And they did this in mouse models and fish models, and it worked. And we tried to reproduce it in Madagascar in human models as just a public health practice, or with West Nile here in South Dakota. We've did it, and we've had West Nile now in the States since 2002. We're running on 20 years of that now. We had a baseline. We had 5, 6, 7 years of good data on human cases, horse cases, positive mosquitoes here in the state. We had chicken sentinels. We had, and then the people at SDSU, they were looking at satellite, the aerial satellite maps of South Dakota, dovetailing that with the weather, with water, with mud puddles, with mosquito density, with humidity at night. And we were able to get, a rough model. Or flu. Our flu model is, I threw that out the window because we know every October, every November, we're going to have flu coming back. Is it going to be H1 flu or H3 flu? We don't know. It's going to peak in February. You get your shot in September. I think that's the only model we need. And the COVID model, what's that based on? That's based on what happened in Wuhan, China, in Italy and New York. We don't have a baseline for that. I know there's, genius people at the University of Washington and at Harvard and Cambridge working on these models, but gosh, I don't know. All I know is none of us have immunity to this, so a lot of us are going to get it. A lot of us are going to get sick, and so just pay attention. I guess that's not very optimistic here. So pay attention, stay informed, keep yourself educated. Go to the CDC website and see what they have to say. They always keep things honest. Don't run off after every rumor and everything you hear. Follow the rules, monitor your own health, stay healthy, stay calm, support your healthcare workers, support people who really can't deal with this. Just stay calm. God bless, keep the faith. We'll get through this, right? I'll turn it back to you, Joel. I've said enough.
Yeah, well, we have a few questions, if you're okay with that. I'll kind of bundle them together. So you mentioned you feel like testing is probably a year and a half down the
No,
road?
Vaccines.
Okay.
Yeah, testing is here and now, but it's very, very limited. It's very limited. And, you know, it's a new test rolled out. So we have to, we have to see how it's going to go. We really don't know the sensitivity and the specificity of these tests yet. So there's a lot of work that needs to be done. Just because somebody has a test doesn't mean it's a good test. It could be giving you a false negative or a false positive.
So then I think going with the testing, when do you think some semblance of normalcy will return?
Well, I think we'll have to redefine normal. You know, we're going to have to make some changes here. And then I guess, you know, the one thing I didn't mention is with SARS. You know, SARS, good grief, SARS just, where is SARS now? It just fizzled away. It just fizzled away. And, you know, hear about SARS, I don't, you know, I haven't followed the literature on it. I assume bats still have it, but I don't know, maybe, I don't think it will, but maybe this one will fizzle out. We just simply don't know what's going to happen with this virus. But I think people are just going to need to get back to, you know, work and school and life and out and friends and family. You know, we're trying to figure this out as we go along. So just be patient. Be calm. Don't, and I know people are running out of money if you're unemployed. You know, it's so hard. It's so hard, but just be patient and let our people in leadership and our scientists figure this out. But I really can't make a prediction. Some say, you know, by the end of May, or when the weather gets warm, but you know, the seasonality, we don't know the seasonality of this virus. It could just keep plowing away through summer till we're really all infected with it. I don't know. My guess is as good as anybody's. We have to do population stuff. Oh, go ahead.
No, I was going to say, kind of going with that, it seems to be questions of finding a balance in the middle seems to be challenging right now, because you talked about the struggle on the one hand with people losing their jobs, businesses closing, and on the other standpoint, a desire to flatten the curve. And so what do you think that delicate balance of sheltering in place versus work, how will that play itself out in the coming weeks?
Oh, gosh. You know, I don't know, and I don't want to, you know, see it that we just drive people into desperation, because people do get desperate. You know, you're in here, you're isolated, you're quarantining yourself, you're at home, you're shut up, and then it just drives people into desperation. And if you're out of money, like, I guess I'm retired now, so I'm getting a pension, so I'm okay. But you know, there's a lot of people that aren't. And people that are living, you know, paycheck to paycheck, even in normal times. And now this coronavirus stimulus money came out you know, this week. So that's going to help people, but that's going to wear thin. And that's not enough for people to pay their rent, or to pay their mortgage, or to pay their car bill, or to go buy food, or all these other things that we need, or pay the electric bill. I think that's going to drive it. Usually we let the science drive this, but this pandemic, this is more than the science. This is psychology. This is economics, and that's something I'm not. And it's also the spirit of the people. It's the religion. It's our faith. It's our trust in God and our trust in each other, and our ability to live in one house with our children. I'm living here with my son. God help me. But no, actually, he's been wonderful. He came back, he left Los Angeles, and because, you know, he had about 3 days notice that Peace Corps was evacuating. He came here, found this house for us, and we've been hunkered down here. He can work from anywhere, so he's here, he's working, and he's a good guy. So I'm very happy for my son. But I don't know, hard questions. You need I don't know, philosophers or ethicists really to talk about this. Probably not me.
Yeah, so here's a question that some people have asked and also impacts us. For those parents who are at home educating their children, and for those working at university like myself, when do you think schools will be able to open in person again?
When do I think? I don't know, but when do I hope? I hope we can have a normal fall schedule. I think we'll have things figured out. We have May, June, July, August. We have 4 months to get things figured out. Figure out the testing, figure out the risk, figure out more the how the epidemiology of this disease, how it attacks people, how we can better protect ourselves. We've got 4 months to get things figured out, but let's get our kids back to school. That's important too. God bless the people that are homeschooling their kids now, and God treasure these young kids that are home. They miss their friends. They've got exuberant minds, and they've got lots of energy. So let's get them back to school, but let's do it right. Let's do it right. Let's figure this out. We've got 4 months to do it.
Another question was kind of the two varying viewpoints of either flattening the curve or feeling the pain of herd immunity. What are your thoughts there as this drags out? Again, it kind of reflects in the last question a little bit of how long can people feel pain, I guess.
Yeah. If you just open the gates, we've seen what happens like in some place in Italy when they've just opened the gates, and it hasn't been pretty, and we don't want that. And we really want to take care of our healthcare workers. They just become more and more precious as this goes on, and we're losing them. Some of them are, they're working probably in the most dangerous. They're among, the most infectious people we have. They're highly stressed. They're in very dangerous in environments. And then, when they have to wear, when doctors and nurses have to wear something like this, a cloth mask, good grief, can't, so part of the self-quarantining and the staying home is for the sake of our healthcare workers. So we can, and like flattening the curve is just keeping the numbers low in the hospital, maybe stretching that out. And I know the healthcare workers, the docs and the nurses and the EMTs and all of those folks will have to work more months, but it'll be more manageable day to day. And I think that's what flattening the curve is all about.
Okay, then we have some questions that are specific to what's going on here in Sioux Falls. So the reality that Smithfield has just created an explosion. A team from the CDC was sent in today. And so I think it goes with, what are your thoughts, for one, on the hot spot that's there? That would be number one. Number two would be the reality that people have probably been walking around infected for 2 weeks in large numbers. And how should people in Sioux Falls be taking that, realizing that they could have come across anyone over the last 3 weeks who's been infected? What steps should they be taking? And then the third one, I think, goes more with isolating and trace contact reporting.
Well, what's happening in Sioux Falls now, and since it's current, since it's today, and since I'm no longer the state epidemiologist, I'm not able to talk about that. In fact, right as we speak now, the governor of South Dakota is on South Dakota Public TV with the Secretary of Health discussing these issues. So I'll leave that to them, but I'll talk in general terms. Yeah, what's happening in Sioux Falls is watch your symptoms, stay home, only go out when you have to. If you're an essential worker, do what your employer says. You should be checking, if you're essential, you should be checking your temperature every day. You should be using some sort of mask if you're working with the public. Just follow the rules, stay calm, don't, and watch your health, and just support each other in any way you can. Keep an eye out for your neighbors. Wave at them through the window, see if their light's on at night, that kind of thing. Sioux Falls can deal with that. There was a tornado that went through Sioux Falls a while back, and that was property damage, but it was really minor compared to this. We in South Dakota, we can handle this.
Okay. And I completely understand you not wanting to give any direction that the health department might be giving, with that not being your world anymore. What about, though, for those in Sioux Falls who feel very anxious now, who it seems like it has just become real in the last week, maybe in a new way? What extra steps should be taken? What words of advice or comfort might you give? Again, we now own the number one hotspot in the nation.
Yeah, we do indeed. Again, it would be very inappropriate for me to talk in specifics about that, but just in general, it's supporting each other. It's, we can go out and we can drive in our car and we can take walks, be outside as long as we keep that distance, and just giving raising your finger, saying hi to people in any way you can, being knowledgeable of your neighbors, your neighborhood, or people who may not be able to get out, or who maybe are too old or too fretful. They might just be too fretful to go to the grocery store. So maybe you could do shopping for them. Be creative. Just think of ways that we can support each other. That's the best thing. If they're running out of milk, make sure that they know that you will help them out. I think it's especially hard because usually our churches and some of our community organizations are our backbone of support in difficult times. And now we go to church online. And I don't know, I find that very difficult, and I get easily distracted. I like to be sitting in the pew, listening to the liturgy or participating in the liturgy, the sermon, the songs, seeing the people, and now we can't do that. So some of our spiritual and our social underpinnings are stripped away from us, and that makes it difficult for us. So it's got to be more the one-on-one support at a distance.
On the other side, you also have plenty of experience with malarial meds, chloroquine, different things. There's talk about that. There's talk about convalescent plasma treatments. There's a whole host of things. What are your thoughts on some of those? Again, there isn't enough extensive research to really tell us, but what are some of your initial thoughts on both plasma and chloroquine?
Well, I'm a public health guy. I'm PhD. I'm not MD, so I don't really. I know about these things, but I really can't speak. I hesitate to even talk too much about that. But I was just talking about that with my son, because who's right over here. He was on chloroquine as a kid in Madagascar for 12 years. He took weekly chloroquine. We called it Nevaquine, and he turned out all right. It didn't damage him, that I could tell. I don't know. Maybe he's now immune to it, or maybe that's why he's so vigorous. Some days he runs 15 miles. I think he ran 6 miles today. So he's strong and healthy. But yeah, but we got to test these drugs. We don't know. I don't know. I really don't want to talk about that, because I'm not an MD, and you really should. I know Augustana has a lot of physicians that could better handle this than I'll talk about the public health end of it, but those are more clinical questions. So, okay. Sorry.
No, as you can imagine, we are getting far more questions than we'll ever be able to get to. So how are you doing there?
I'm losing my voice. I lost my eye. I got back from Madagascar and I can't close my eye. So it might just be the ravages of old age. It's not coronavirus. But
so with that,
no,
but it seems like coronavirus is having a variety of things. So what are you reading, not being on the MD side, but on the public health, for those that are losing sense of taste or smell, or a whole host of pieces there?
Yeah, that's a very interesting thing. We've never really tracked that. However, now in our data set here in South Dakota, when we question cases and contacts to cases, that's one of the things that we ask about, because we need to find out more about that. Is it 100% of the people with coronavirus lose their sense of smell? Is it temporary? Is it 50%? Is it just the men? Is it just the smokers? Or is it the kids that vape? You know, we need to define these things. We need, and I hate to say research, you know, I like that. I like to do the epidemiology of it, but we really need to find out more about this and see if this sense of smell, maybe we should all get up in the morning and, I don't know, have a little pot of, you know, something stinky there and just smell it. And if we can't smell it one day, well, that might be, you know, the first warning sign. You know, I don't know. You know, these are things that we should be looking into now. It's fascinating, absolutely fascinating.
What about how different surfaces, whether it's a hard surface, a porous surface, clothing, it seems to be surviving longer on different ones. How does a virus go about doing that?
Yeah, you know, all viruses, you know, some are very fragile and they die within minutes or hours when they hit a surface. I understand this virus can live up to 3 days, but even that's, you know, very, very, you know, has lots of nuance to it, because if it's a hard surface like a piece of glass, if it's cold, if it's dry, what the humidity is, if you're going to cough hard, if you're going to get some nasal discharge on a surface, it can live hidden in that for a while. So I hate to say, you know, oh, within like 8 hours it's going to be gone, or within 72 hours. Just be careful of surfaces. Assume that every surface is contaminated unless you really know for sure. That's why we always say just wash your hands when you get back home. Use the hand gel. And what I want to iterate though, these are viruses. They're not spores. This is not anthrax. Like a spore can live for 100 years. We found that out in South Dakota, and some of these, when cattle get anthrax, a spore can live a long time under adverse weather conditions. But viruses are not spores. They will die. So, you know, Andrew and I were just talking about our house here that we're camping in. You know, there'll be, I don't know, a couple of weeks between us moving out and maybe the people who are snowbirding in Arizona will come back. You know, if I have any viruses, they should, you know, be dead by then. And you know, we'll vacuum up and we'll wipe everything down. But you know, that should do it. But yeah, you know, the viruses, they don't really live, but they survive on surfaces. So just assume that everything is contaminated unless it's in the middle of your house.
Yeah, you brought up in your last answer, both soap and hand sanitizer. There seems to be a lot of questions there where people are washing their hands and then using hand sanitizer after soap and wondering, talk about both the strengths of both, what you recommend.
Yeah, well, wash your hands in soap and water for 20 seconds. That's the best. That's better than hand sanitizer. But if you're out and about, and then you can use a sanitizer, you don't need to use both. And now, you know, the rumor mill is starting, and all these, and you can't buy hand sanitizer. I haven't seen it for sale here in Pierce, South Dakota, since I've been back. You hear people saying, "Oh, use mouthwash. Just use some Listerine and do that." Well, you know, that hasn't been tested and proven at all. And people are going to come up with all kinds of, you know, things they're going to see on the internet, or or things that their mother-in-law told them or something. But hand washing, that's first and foremost, and then the hand gel. You really don't have to use both. You know, I was just in Madagascar, and most people don't even have soap if they live out in the country, and the theme is use ash from your cooking fire and wash your hands.
So another question that came in seems to be that it has not yet impacted Southern Hemisphere, or those that were experiencing summer more. Is there any research yet that might give an insight into how Central America or parts of Sub-Saharan Africa might be impacted now more?
Well, the other respiratory virus is, of course, influenza. And we have opposite seasons, especially in temperate southern hemisphere, like Argentina, Australia, South Africa. It's the months of June, July, August. They're cold months there that the influenza gears up there. In fact, we watch that here in the United States. We're always looking to see what viruses are circulating in Argentina, in Australia, and in Tasmania and South Africa. Now, tropical Africa, however, there's really not such a defined influenza season. There is influenza. I went, 2013, I went to Abidjan in Cote d'Ivoire in Ivory Coast, part of the CDC group, and we were looking into doing surveillance for novel influenza viruses there. And one of the things I was interested in was the seasonality of it. And you just don't get that. It starts in October, goes up, peaks in February, and goes down. You don't get that in tropical Africa. Madagascar now has just over 100 cases. Of course, testing is minimal, and going to the doctor is minimal. So, I don't know, but we really don't know what it's going to do in the tropical countries. These viruses, they do act different just because of the climate and poverty too. If it gets into a big city in the tropics, like Lagos, Nigeria, or Kinshasa, Nairobi, Antananarivo in Madagascar, it could be absolutely horrendous, absolutely horrendous.
We'll do two more questions. You'd mentioned that for older populations, those at risk, this can be a particularly terrifying reality. Have you read any studies that have talked about why it seems like young children or babies are not impacted the way some other viruses can impact those without established immune systems?
Oh, my thought would be better immunity. Like the H3N2A influenza virus. It likes old people. It really attacks old people, where the other, like the pandemic back in 2009, the old people had a little bit of immunity to that from way back when, and that picked on young people. So you never really know, but it's got to be part of the immune system. It's got to be part of the immune function.
Okay. And then the last one deals with people who might have been sick in March with fever, chills, aches, and thought it was a seasonal flu and maybe didn't realize there was a chance. Should they be anxious, or should they be more confident, or what are your feelings on those who might have been sick in the very recent past but didn't get tested?
It could have been anything. It could have been influenza. It could have been Joe Blow, generic coronavirus, a rhinovirus. There's so many of those things. Just assume you didn't have it unless you're actually tested and can show that you had it. And even if you test positive for IgG and IgM antibodies, you don't know if that test it shows that you had it, but it doesn't show that you have immunity. We're still studying these things. We've only known about this virus since late December. We have a lot to learn. We have a lot to learn. So don't think you're immune just because you were a little sick here a month ago.
Yeah,
try that.
Okay, I'm going to sneak in one last question that came up, and it deals with pregnant women and the challenges there, or potentially passing it along to a newborn.
There have been infants that have died from it here in the United States and abroad. That has been reported, so that is possible. We have, obviously cases here in South Dakota where young children are. This was a family thing too. My nephew and his wife just had a baby in Sioux Falls here last week. I think it was, yeah. Just very recently. So it goes on. Babies are going to be born, and you have to protect them as well. And we don't know yet that much about how sensitive they are. So really protect your children. And even for if not in this season, during flu season, don't take your little baby out. There's pertussis, there's flu, there's all kinds of stuff going around. So really be protective of your baby, especially in this day and age.
Well, Dr. Kightlinger, thank you so much for joining us. Thank you for all the information you provided. Thank you for even some of the questions we asked that dealt with current realities in Sioux Falls and South Dakota public health, with your ability to be nonpartisan and not entering the fray, because it seems to be like people are longing for information that comes from one side or the other. And so thank you for that. And thank you for helping to educate us more so that we can be a little bit better understanding of what we're going to be facing in the weeks and months ahead. We really do appreciate it.
Okay, well, thank you. And I suggest that the next person that you get on, you have lots of talent there at Augustana. You get an economist to answer these questions. You get an ethicist. You get a pastor. You get a physician. You get a virologist. I could give you a few names, but you know, I'm just a public health guy. I'm just you know, an epidemiologist. So you know, that's what I know. That's what I'm experienced. I'm over the hill already. So.
Well, perfect. Well, I will put in a shameless plug. We are also starting, it's going to be kind of a podcast conversation with campus ministries, the Department of Music, and ourselves, just interviewing different alums, talking about how the virus is impacting them. And we recently spoke with a physician at Avera who is a pulmonologist and obviously working in the ICU, and how that is going to be impacting her and currently is impacting her. So,
okay, excellent, excellent.
Yeah. But thank you so much. Have a great evening. Enjoy time with your son.
Thank you. Thank you.
All right.